Hello, I'm Rachel Reid. I'm talking to you from Australia, Queensland, and I'm going to talk to you about birthing without directed pushing. So first of all, I'd like to look at reframing and reclaiming physiology and instinct as the foundation of birth knowledge before we look at the physiology. So the origins of our current knowledge and practice really come from science and medicine, and that emerged from within a culture that viewed the female body as inferior, an inferior malfunctioning version of the male body, and the human body as a machine that could be managed as such. And that technology in medicine, we could make the body function more effectively and be less dangerous and more controlled and ordered. So you see that now playing out in modern birth culture, particularly in Western birth maternity systems. So we have large-scale medicalisation of birth, which means that physiology is not the norm. So if we look at the statistics, the majority of women are not having a physiological birth. So they're not starting labour spontaneously, going through their entire labour without any medications or interventions, and then birthing without surgery or instruments. So this means that the research, really since kind of the 90s, has been evidence-based research has come into play, and that's been carried out on women who are not having physiological births, who are in institutional settings. And care providers are primarily caring for women who are not having physiological birth. And risk is still conceptualized as being located within the woman's body. And the interventions that are implemented are often attempting to manage complications that have been caused by the interventions that were implemented before evidence-based practice. So in terms of shifting the current knowledge practice paradigm, we need to reclaim birth knowledge that has a foundation in physiology and reconceptualize risk to include the environment and the care provider actions and interactions with the woman. And focus on promoting physiology and instinct as a risk management strategy. So flipping that risk management on its head, and clearly define and differentiate practice during physiological birth versus non-physiological birth. Because in a context where physiological birth is not the norm, then it can be really difficult to understand when intervention is necessary and when it is actually a risk. And with a non-physiological birth, there is a necessity often to carry out interventions. So let's have a look at physiology and instinct. And I'm going to first just look at physiological birth. So again, this is women who are not birthing with intervention. So I'd like to thank Rachel Rose for offering her photographs to illustrate the physiology of birth. So you can see here, Rachel, in the liminal phase. So the picture on your left, she's really deep in that, what I call the liminal space. So high endorphins put the woman into an altered state of consciousness. She's kind of, she's really focusing within and doing a lot of work, contracting strongly, high oxytocin, high beta endorphins. And, if the baby came out at that point, she may not be able to, manage and look after the safety of the baby because her neocortex is pretty much downregulated and her limbic system is really strong and instinctive. So what happens is she needs to come back a little bit from that in order to care for the baby that is about to be born. So this is where transition comes in. And what happens in transition is the woman experiences a huge boost of adrenaline, which kind of activates the neocortex again. So women end up in this kind of, altered state, but still now connected to the external world. And as the woman goes through transition, she'll often reach out, having been very closed-eyed, kind of not looking outwards, she'll reach out to her care providers. She'll often feel fear, because if you have a boost of adrenaline, you get that fear. So she'll often, shout out for help, so she can't do it anymore. Rachel told me that at this point she was asking to go to hospital, that she couldn't do it anymore over it. That's really classic transitional behaviours. And the reason for that is to bring the woman back out of that altered consciousness to a point where she can birth her baby, because there's work now to be done. So instinctive physiological pushing. So at this point, the woman's almost like, I call this witnessing her body. And women say, you know, this push came into my body. This is, but because the neocortex is functioning, the woman gets to witness this really instinctive physiological process. And the purpose is, again, so that the mother can protect her baby and also increase bonding behaviors post-birth. So the thickened muscle of the fundus, so the top of the uterus is really thick at this point because it's pulled all the muscle fibers up to the top, starts to push down with contractions. And as the baby descends, it presses on those nerves in the pelvis, and spontaneous pushing builds and becomes increasingly expulsive, and the muscles of the abdominal wall and diaphragm start to join in. And the woman will often make those guttural pushing sounds, you know, that real deep down kind of grunty, throaty sounds as she's pushing. And her breath will adjust to oxygenate the baby. So the contractions often space out at this point. And women will breathe, often during contractions. They don't breath hold like directed pushing. So they'll breathe to oxygenate their baby. And that depends on that individual mother and baby and what's needed and what's best for them. And as the baby's head becomes compressed and the baby moves through the vagina, the baby gets slightly hypoxic. And this is really important for initiating those adaptations to breathing once the baby's out. And birth is supposed to be slightly stressful for a healthy full-term baby. And instinctive movement moves the baby through the pelvis. And this is really important when we look at supporting women in labour, because women will instinctively move in a way that best facilitates their baby through their pelvis if they're not being directed. And sometimes they'll do very strange positions that make no sense to somebody on the outside but work perfectly for that mother and baby. So there's this birth dance happening between mother and baby to move the baby through the pelvis, and it's dynamic. There's lots of movement happening. There's very high oxytocin, ready for bonding, high prolactin, ready for mothering, and beta endorphins are high. As the baby's head crowns, there's another adrenaline surge, because this extreme stretch often is accompanied with pain and another surge of adrenaline. And that stretch actually initiates the behaviors that protect the perineum. So the woman will actually slow down the birth of her baby herself. She'll stop pushing and adding into the pushes. The guttural sounds of downward, you'll often hear they'll come up and out like a scream or a much higher sound where she's avoiding pushing down because it's really intense. The woman will often put her hands between her legs like Rachel is here and close their legs, which then gives more stretch in the perineum. So all of these things are happening instinctively, not thinking, and they're all protecting the perineum. So these behaviors are protective. They are risk management. Physiology is managing the risk of perineal tearing by slowing down the birth, and the mother is enacting protective mechanisms. So as the baby moves further and further down, the head is actually born without the additional pushing of the mother, because she's holding back. And the baby's head presses on the clitoral structure, which is kind of wrapped around the pubic bones and around the vagina. And the baby's head presses on that as it starts to crown. And that pressure initiates kind of short pulsatile muscle pushes, which push the baby's head out kind of more gently and slowly than a big as the baby moves down, the sacrum also pushes the baby's head towards the pubic bone. And there's a slight pelvic tilt of the mother as the baby kind of comes through that part of the pelvis and presses on the clitoral body. So you can see here Rachel birthing a baby, and he's being caught. So you can see here her legs are quite close together. Standing up does increase the risk of tearing, but if the woman has got into that position instinctively, you need to trust that she'll protect her perineum. If you've told her to get into that position, it's a different matter. So once the baby's head's out, there'll be a space between contractions so that the baby's got time to use that space and that relaxed uterus to change position, to get its shoulders ready and aligned to come out, and to drain all the fluid from its nose and mouth, which you'll see happening if you're watching. So that's physiological birth. So that's the scream happening as all of that kind of pressure is brought up out of the throat rather than down into the bottom. And you can see that, Rachel's neocortex is obviously activated to some extent because she's able to help catch her own baby. Now, usually what I tend to see watching physiological birth is women birth kneeling down on all fours and the baby ends up between their legs. Here, she's standing up and she's helping catch her baby. And you can just see the midwife here in the corner, which is where the midwife is when they're supporting physiology and instinctive birth. And then Rachel has helped to lie down and relax. And this is a classic, you've had this massive high endorphins, high oxytocin. This is the euphoria that comes after birth. And you can see it closely here. And then the mother and baby move into the next phase, which is the working together to get the placenta out, which is a whole other presentation. So that's physiological birth in a nutshell. So how can we, as care providers, promote and support physiology? So we can accommodate the birth dance, and certainly the history of midwifery, if you look back into the past at what was written about midwifery practice and what was depicted about midwifery practice, it was actually about supporting the woman to move in this phase of birth. And that would depend on the culture, so some cultures, the midwife would throw a rope over the rafters for the woman to hold on. In other cultures, the midwife herself would become like a birth chair for the woman to actually sit on to birth her baby. And it was this helping the woman move her pelvis to get the baby out. If she needs to, some women will move about without any assistance. And particularly in a hospital setting, for example, the woman's unfamiliar with the environment. The midwife or care provider might need to be the person who's moving the equipment around to accommodate her needs, taking the birth bed to pieces, encouraging her to use the environment to move. And the movement is dynamic. So when you watch women instinctively birthing, and if we look at historical records of women birthing, they don't get into one position and stay there. Of course, the pictures show that, but often there'll be a series of pictures of the woman moving, because it's the pelvis is biggest when in moving. So, for example, certain positions like squatting open the pelvis, but it's the moving into the squat that actually opens the pelvis more than the squat itself. So that it's really important that this movement is not just a static birth position, which we tend to get women into when we're directing them. And it's about accommodating and not directing. So there may be something happening inside that woman's pelvis that you don't know about. I have seen women take up some very strange birth positions that made perfect sense after the baby was born. So don't project what you think should happen, because in the textbook, this particular position says the pelvis is bigger, because for this woman, mother and baby, that position might not be appropriate. So the other thing that we can do is affirm instinct. Now, Nikki Leap calls this midwifery muttering. So the woman's neocortex is activated again. And because we're humans and we think, there can be a lot of talk that women do. Am I making progress? This baby's not coming out. It hurts. I can't do this. So some women need that reassurance. And certainly research reflects that midwives do that. We say things, you're doing really well. The baby's coming, just reassurance. So it's not direction. It's reflecting the woman's body wisdom and instinct, saying to her, trust your body, you're doing this, rather than telling her how to do it. And that's affirming her instincts. So those are really the two core ways that we can promote and support non-directed pushing during a physiological birth. So that's accommodating the birth dance and affirming instinct rather than directing. Now, things get a little bit more different when we're looking at women who are having non-physiological birth, because they may require interventions. So there might need to be adaptations to accommodating the birth dance. So you may need to be using techniques such as rebozo, such as asking the woman if she would like to change position and helping her to move position, even with an epidural, as far as she can, because she's unable to do that and for herself if she has an epidural. And it's not about affirming instinct so much, because women who are having non-physiological births are often not in that altered state. So if they've had an epidural or Syntocin on, then this is not physiology, but she is still the expert. So it's about affirming her capacity and autonomy, that she is still the main decision maker. She is still the person birthing this baby. So it's framing everything within that, rather than you being the expert and taking over her birth. With an epidural, then passive, and I'm saying passive because actually the woman should be supported to be moving through this as the baby's moving downwards until the baby's head is on view before commencing any guided pushing. Will help to oxygenate the baby, and it will improve outcomes in terms of the woman's more likely to get the baby out before the baby gets stressed by any guided pushing. Now, I've said question guided pushing rather than direct. So you can still work with the woman, affirming her capacity and autonomy when guiding pushing for a woman who can't feel what's happening. So this will look different depending on the woman and the circumstances. For example, a multip, even with an epidural, will likely the baby will come out without any pushing. For a primip, she may require some guidance, and it's about trying to connect her with what's happening. So instead of, saying chin on your chest, push into your bottom as hard as you can, ask her what she can feel. Can you feel, can you feel that pressure as the contraction rises? And then, say to her, okay, so if you feel that, then push down with that. So it's getting her to really listen to her body as far as she can and work with that. So that's guiding pushing rather than the standard Valsalva maneuver, which we know causes harm not just to the woman and her perineum, but also to the baby. So that's all that I want to talk to you about. It's a way of kind of reframing how we support birth without directing and instead affirming and adapting that for women who are having non-physiological birth.